This is Charles Denham, Chairman of PMIT, welcoming you to our monthly webinar. Thursday, we have a wonderful topic with some great speakers. And the title of our webinar is Quality and Safety Leaders' Critical Issues, Patients and Families as Team Members Vital. And what I'd first like to do, and Kyle, could you give me control to advance, please, sir? And what I'd first like to do is cover just a few housekeeping details. I'm now on slide 3. I would like to make sure that everyone gets their volume up on their machine. For the newcomers to our webinars, you need to make sure that your volume is up on your own computer if you're listening by computer. And if for any reason that you have difficulty, you can click down in the lower left-hand corner, request phone, and go ahead and get an additional line, a direct line, and that will help. I'm on slide 4. You may go to www.safetyleaders.org to click on the area where you may download the slides, and this is on our landing page, and I have that slide up, slide 4. And when you do, you'll see one of our lovely speakers, Karen Curtis, and a place to download content regarding this webinar and the slides. Moving to slide 6, I want to remind everybody that we are on Twitter and Facebook. Hashtag #safety leaders is the hashtag. Slide 7, our mission is to save lives, save money, and build value in the communities we serve. We're very blessed to have a wonderful audience every third Thursday each month, helping us with that mission. And it's an honor to provide this webinar at no cost to so many hospitals, including our safety net hospitals, who we're really privileged to have with us. Our disclosure statement, I won't read it. They're on the slides. And in no way are there any financial relationships between our speakers. Karen Curtis will present her book, and we are embracing and endorsing her book with no financial relationship. And if I move to my next slide, I have a picture on slide 10 of Mary Foley. And it is our custom to have the voice of the patient and family be expressed at the beginning of every one of our webinars with a 30-second statement from an activist, patient, or family member of someone who has had healthcare harm. And it's such an honor to have Mary Foley not only open us with a 30-second statement. She has experienced loss in her own family and dedicated her life as a nurse and a nursing leader and educator to help us. So she speaks from 2 positions today, 30 seconds now, on behalf of the patients. Would you set the context for us, Mary?
Thank you, Chuck. Thank you, everyone, for joining us this morning for such an important conversation. I'm really honored to be sharing the time with you today, and particularly with Karen Curtis, who I'm just very privileged to have met this year and find her work to be really contributing dramatically to the conversations that patients and families want to have and must have with our healthcare system. So, Chuck, again, thank you for your continuing support of the voice of the family and the patient. This is so important. Our leaders know they want to do the right thing. They sometimes don't know how to do it, and I think these conversations help us all and guide us all in doing the right thing for the right reason. So thank you again.
And thank you, Mary, for your contribution and having had loss in your family, stepping up and reliving that on the behalf of other patients, families, and activists. You've just been a wonderful contributor. We look forward to the interactive dialogue at the end of our 2 speakers. Now I move to slide 11, and you'll see the pictures of Karen Curtis, who will share with us a fantastic new book, and there'll be another issue coming out that she'll share with you, and really focus on how patients and families can partner with us. Now, this webinar is specifically and intentionally providing that voice so that nurses, frontline caregivers, doctors, administrators, all of us can learn from some of the innovations that can be applied and provided to patients. We then have Tom Knight, I think one of the greatest patient safety leaders in the country, who's recently moved to Austin, Texas, a longtime friend, a longtime contributor, one of the best read and most knowledgeable and humble leaders we have. I think of him as a Collins Level 5 leader. He'll address the critical issues that our safety and quality folks need to address. And we'll have Mary and then Angela Clemente, and we're all kind of connected together to some degree because Angela is a transplant patient who's on the waiting list. There are 105,000 patients on a waiting list for organs. 17 die every day. She is in clear and present danger today. She is a knowledgeable professional who is now trying her best, and somebody who really understands documentation and from her former profession, having great difficulty interacting with the healthcare system in order even to get on the transplant list. And then we have Frank Ghiotto, our wonderful Chief Technology Officer, that will take us through SpeakerLink and connections that we have with our teams. I'm going to click through very quickly a few slides just to give us a little bit of context. And at the very end of the webinar, I have the privilege of meeting with somebody who you'll see on my slide deck, and I will probably leave just a little bit early and allow Frank to close us, as well as Mary. Slide 13 is the National Quality Forum Safe Practices for Better Healthcare, Safe Practice 1. At Leapfrog, we weighted it most heavily. I know the recent scorecard by Leapfrog is very controversial. We were not involved in that scorecard, but it does call on the NQF Safe Practice, which is part of that scorecard, and the original weighting of Leapfrog's original rollout big survey tied 300 points to this safe practice, which addresses the structures and systems that are absolutely critical. Slide 14, I won't read the slide to you, but I'll reemphasize why TMIT is putting such emphasis on governance boards and trustees, that it's important for them to address identification, mitigation of risk and hazards, as well as culture measurement and feedback. On slide 15, the governance boards critically to start becoming involved, and especially with accountable care in safety, risk, and hazards. I think the medical records issue, interacting with patients and families, is absolutely a huge risk area, but as Tom said just before our meeting, a wonderful opportunity for improvement. Safe Practice 12, which is slide 16, and again, this set of safe practices can be downloaded from the National Quality Forum, and TMIT is putting a lot of energy into updating these practices to resubmit to NQF, is patient care information. And Angela, we'd like in the Q&A session for you to comment on some of the challenges that you've shared with our speakers before we got started. We're 11 minutes after the hour, started a little late, so I won't read the elements out of this practice, but the specific specifications address how critical it is to get care information transferred from the system to patients and families and back again, and how important it is to report gaps and close the gaps that we have in these in this area. And you see on slide 18 that we must ensure that patients have access to their medical records. Angela will share with you, I spent 20 to 30 hours personally trying to get Angela's medical records from one hospital that is 2 miles away from the other hospital in order that she could get on the transplant list and get everything in my power as a physician to help her. Without that, she never would have made it into the transplant team. So as we look at Safe Practice 1, Culture of Leadership Structures and Systems on slide 19, I want to remind you that we need to have direct patient input, and Frank Ghiotto will address SpeakerLink, and we'd like to have Karen Curtis address this wonderful and increasing and very important partnership with our nurses. This is, we provide continuing education units for nurses for this session. I'd like Karen to actually emphasize how, through using her book, patients and families are interacting and can optimize their relationship with caregivers and the transfer of information. And I'll close my little introduction regarding Clayton Christensen, who I think one of the finest men on the planet. He's one of the most loved professors at Harvard Business School. As a senior leadership fellow in advanced leadership, I've had the pleasure of really getting to know him. He's in our recent movie, Surfing the Healthcare Tsunami, and I will be leaving a few minutes early this webinar to have my one-on-one meeting with Professor Christensen on the work that we'll be doing together, and the third movie, discovery movie we're working on, which is Healing Moments. He's and just the introduction to him, why he will be so passionate, and I think, Karen, appreciate the work you're doing, is that in the space of 3 years, he's had a stroke, a heart attack, a retinal detachment, and a stage 3 cancer of the same cancer type that his father had, and he's had a heart attack. and came back from that and learned to speak. So here's someone that could really understand the giving and loving, tender care that caregivers give, but also the importance of healing. And two books I highly recommend, no relationship with either in a financial way, is Happier, the most strongly supported course at Harvard, which is a structured way to bring joy back to life, and Clayton Christensen's recent book, How Will You Measure Your Life, which is what we'll focus on in Healing Moments, our next movie. So what I'd like to do now, and I think we're doing well on time because I rushed a little bit through my slide deck, is to have Karen Curtis share with us. And Karen, I'd like you to really, rather than me take time to share your bio, introduce us to you, and please take over, and Karen will give us a 20-minute overview of the wonderful work she's done, the book that she is distributing, and the passion behind it. And I think, Karen, I'd love you to introduce yourself and your bio.
Thank you very much, Chuck, and thank you all for the privilege of being here with you today. I certainly applaud all of your efforts for health literacy for patients and families to engage them in care. I have had the privilege, actually, of working with Mary Foley quite closely in developing nursing curriculum around my book, Safe and Sound in the Hospital. That was published just last fall, and since then we've been working closely with a number of hospitals and one major insurer who are determined to get this book into the hands of patients on sort of a just-in-time basis. I learned through Campaign Zero, which is a nonprofit that I founded a few years ago, where we offer a free ebook of checklists for patients and families that oftentimes people don't get to the website until there is a problem. So while I'm really happy that we have great traffic and that people are coming and that they are able to download our free checklist, if it's after a problem, that was very troublesome to me. So we are working to get this into, as I said, patients and families to help preempt problems. And Mary and I and our team are working on curriculum so that patients and families can work side by side with nurses, and that it's a good collaborative win-win relationship. So today, I thought just as a quick overview of what we'll cover, I'll talk a little bit about how I came to this work, why Campaign Zero is so important, and why I took the time to write the book and why it is, a professional and personal passion. A little bit of an overview of health care quality in the U.S., and I think all of you are very familiar with that, so I think that's probably why you're here on the call today. And then I'll show you an example of some of the simple little checklists for families that can make a big difference in outcomes. What I hope you'll take away today, and I'm so sorry, I've been forgetting to advance the slides. Okay, so here, what I hope you'll take away today are the specific ways that families can be effective partners and their loved ones' care. And we'll just take a quick look at three of them in particular that are on the website at Campaign Zero, and then, of course, in the book, hospital-acquired infections, bed sores, and falls. A little bit about me is that I am a mom, daughter, wife. I don't know if it's necessarily in that order, but those are all very, very important roles to me. We have 4 children, and I'm one of 6 kids myself. I had a 25-year career in marketing from the time I left college until my dad was sick, really, until he was diagnosed with idiopathic pulmonary fibrosis. I worked for Fortune 500 companies in market research, which is a lot of data mining and analyzing it, and and then advising my clients about, new products, communication strategies, and other kinds of activities, mostly for Fortune 500 companies. I abandoned this career, however, when my dad became sick, so sick actually that he was at end stage and needed a lung transplant. As you all know, they're hard to come by, especially for IPF, which is a pretty rare disease. 1% of all IPF patients get a lung transplant, and my dad was one of the very lucky ones. In fact, there were so many miracles along the way to the transplant table, and one of them was that he received a lung transplant only 3 days after being listed by UNOS, which you know is really, really a miracle. And he was well on his way to recovery when he suffered a fall that went unattended. It was a fall on a Friday afternoon, went unattended until Sunday night, and as a result, he contracted pneumonia. Then that cascaded into a lot of the things that you're very familiar with, things that can happen when you're in an ICU and immobile, blood clots, which led to an embolism to his new lung. He did have 3 bouts of MRSA, C. diff, and a stage 4 bed sore that really was just horrible. He came out of surgery with it at level 1, stage 1, but it really wasn't attended to very well and progressed to stage 4. After 7 months in the hospital with my dad, my husband had a routine bowel resection, which had lots of problems. He eventually ended up with VRE and sepsis. And my son, during the same time, who was 9 at the time, was misdiagnosed with appendicitis. I really was helpless, and I just felt that I had failed miserably, especially for my dad, because he did not survive, despite the fact that his prognosis coming out of surgery was absolutely wonderful. His doctor promised him that he would be back on the golf course in a matter of, 4 or 5 or 6 months, but he did see a good future for him, except he took that fall. And it was very hard, it has been very hard to shake the feeling that our family, all 6 kids, were bedside with my dad and my mom. We took turns, but I think I was there the most, along with my sister, who is a nurse, and my mom, that he was really trusting us to watch out for him. But we have we felt like we failed. So I felt like the book that I wrote is the book that I wish that I had. We did a lot of digging, and we found out that it wasn't bad luck, it wasn't bad medicine even, it was just a pretty much cracked systems. So my personal epiphany was when Medicare pronounced all of the things that my dad went through, and my husband, and even my son, that these were never events, which is the reason why we named it Campaign Zero. So going through the data again, we know that it is vastly underreported, probably at 13 million or 1 in 3 patients, and that 309 lives are lost every year. We know that the human costs, of course, are immeasurable. So one of the things that we do is we feel that family members are really the most patient-centered care partners that any hospital could have. So we coach people in our checklists and in our and in the book to ask questions, speak up, know when to pitch in, take good notes, and stay connected with their loved one after a hospital stay to prevent a readmission. So it all starts with a notebook, whether they want to buy the handbook that I wrote, or if they just pull one off the shelf at Target. This is probably the most critical tool of all. It's not high-tech, but it works. So here's just an example of one of the checklists. It doesn't have great resolution, but you can see that the number one job that we advise care partners to take on is preventing infection, and the number one job that they need to do is just wash their hands and get others to wash their hands also. So we explain that there are simple tools. They can pick them up in the hospital supply closet by asking permission first. We tell them all the surfaces that need to be cleaned vigilantly, both with bleach and with alcohol, in order to prevent infection. I remember all of those hours and hours of sitting next to my dad's bed. If I had only known that I could help prevent infection by taking alcohol wipes and bleach wipes, I would have been very, very pleased to do that. It's really a simple thing, but it could have meant a big difference between whether he was in the ICU with MRSA or not. And the same for my husband, who picked up a VRE infection. Another example of the tools is that we give them the checklist of how to be vigilant for bed sores, and the kinds of things to do to help prevent bed sores, which are simple things like how to get in and out of bed without scraping fragile skin. We also tell people in all of our checklists who's most at risk. And why are they most at risk? And they're in very short phrases, and I should mention all of our checklists, all of our materials are written at the 6th grade level. But by knowing a little bit about the potential problem and who's at risk, I think it kind of helps drive it home that it could happen to them. So we give them not only the checklist, but we also give them ideas for these simple tools. A watch. We all wear watches, or it's on our phone. We can time every 2 hours, which is the ideal of when a patient, gets up and moves about or is helped to move if they are not able to do it on their own. We show them pictures of the types of cushions that they can ask for and where those cushions need to be placed. So that's very simple, and families can definitely pitch in. Fall risks are huge. I think very few people think of themselves as a patient before they go into the hospital as a potential fall risk, especially if they're the kind of patient like my husband who ran 5 miles a day and then stepped it up the day before he went into the hospital and lifted weights. He, of course, was a fall risk. No matter how athletic anyone is, the medications, of course, do a number on your mental faculties, but people do feel weak after surgery. So we just tell people in these checklists, point out all of the furniture that's on wheels. Help make sure that you're always around to give them a hand to help them steady their walk. We have in the book, we have these little pull-out signs that people can tape to the bed rails or the door of the bathroom or the door to the room to help everybody remember that this patient is at risk. We also recommend that they invest in those cute little red socks, or it doesn't actually matter what color they are, but that they have the grippers on the bottom and that they don't hesitate to ask for canes. There's no need to be hesitant. Actually, we tell people in hospitals to ask about any supplies because they're all right there. We also have these simple checklists. These are just a few examples, but the other topics that we cover in checklists and cover, the simple tools as well is for C. diff and pneumonia, blood clots. We talked about the bed sores. urinary tract infections, medication errors, wrong site surgeries. We also advise people how to help their loved one prep for surgery. Simple things like helping to keep their loved one warm does make a difference in infection rates. How to manage visitors and why it's important, to keep a very quiet arena around your loved one, and to be very, very considerate of other patients as well. How to keep good medication records and why it's necessary. We actually promote the fact that they can help bridge communication between all the caregivers, especially like at handoffs or during other kinds of care transitions, for example, to home. How to keep track of tests and results, and how to plan for a safe discharge home and to prevent a readmission. Because oftentimes families accompany their loved one in the hospital, but then they have to drop the loved one off at home and then get back to work. They need to have a backup plan if that's the case. So the motto on the front of our book is, to the world you are but one person, but to one person you could mean the world. And this goes for not only families, but also for nurses and other professional caregivers as well. So that's what we're all about, and I guess we'll be able to ask questions later if you'd like to.
What a wonderful walkthrough. Thank you very much, Karen. We'd like to move to Tom, and we'd like to have Tom take us through critical issues and connect some dots for us on how important it is to engage patients and families as you now talk about critical issues for the safety and quality leaders for 2012.
Okay, well, thanks. I'm very happy to be with everyone today. I'm going to try to go through, we could rename this, instead of issues, challenges. And so basically, I think you're all familiar with Chuck's no outcome, no income tsunami, and this tidal wave of measurement and regulation and public reporting and payment reform that's sweeping across the healthcare landscape. And what I'm going to do today is kind of relate this a little bit to how this is affecting us in the quality and safety world, how it's helping us draw attention to appropriate issues, but also how it's creating some diversion, if you will, of some of our resources from areas that I think we really need to be focusing on. I think there's a big move, and the federal government, especially who is the main source of these measures, is starting to get it. But I just want to go through some of the challenges that we're facing today and struggling with. And then I want to also talk a little bit about some of the challenges that caregivers and patients face in our healthcare system, and kind of give you a little bit of advice in terms of how I would advise patients to view the quality and safety system in this day and age. Next slide, please. I'm going to divide this really into, I've actually combined the bullet point number 4 with number 3. So I'm going to really divide this into 4 areas: data versus information, what I call chasing windmills and unicorns instead of icebergs, moving from informed consent to informed choice, and then the final curtain, a little bit about end-of-life care. Next slide, please. I actually may have liberated this slide from you, Chuck. This is 10 years old, believe it or not, but this is a report back in 2002. And the point of this slide is we have lots and lots of data. Our IT function here at St. David's Healthcare now, within our computer systems here, we now measure in terms of terabytes of information. That's a 1 with 12 zeros after it. So we have lots and lots of data in this incredibly complex healthcare system that we live in today. The question is, how do we turn that data into more actionable information? Next slide. So this is one of my favorite quotes, and another thing that we struggle with daily. In some ways, this relates to Dr. Don Berwick's 2007 keynote IHI address, which, if you haven't heard, I highly recommend. It was called Eating Soup with a Fork. And the point being, as complex as healthcare is in this day and age, and the argument is that healthcare systems are the most complex institutions on earth, and I have another talk with a lot of data to back that up. We always must keep perspective. When we look at data, when we try to let that data drive our actions, we always must kind of take the 360-degree look as well as the 30,000-foot and reality test. So next slide, please. So I'm going to start with data versus information. You know, we kind of, as a society, have this inherent trust in numbers. If you put a number up there as opposed to a word, we have a lot more trust sometimes than we should in a number. And in healthcare, I tell you what, if we just color that number red, it gets everybody's attention. So a red number in healthcare really gets things moving. But when we look at a number, we really need to think about several things. Number one, the power of that number. What is the statistical power, especially if you're talking about something like say, for instance, observed versus expected mortality ratio. What is the power of that number to measure a difference? Number two, how accurate is the data that number was derived from? And number three, can that number be translated into action? Is it actual information, not just data? And I'm going to give you an example of how that goes poorly sometimes in healthcare. I was at California Pacific Medical Center in San Francisco when the state of California decided to publicly report ICU mortality. So we sent in chart abstractions of all our deaths in our ICU, 65-point chart abstractions, and they did this big calculation statewide, and we ended up with a mortality of 11.1 observed to expected versus a statewide of 10.9. And, you know, there were a couple of issues with that. Well, first of all, finally they sent us our confidence intervals. And by the way, the 11.1 turned red, and it got a lot of attention in it was publicly reported, got a lot of attention in our institution. We spent a lot of time working on it. But basically, the couple issues. Number one was that they finally sent us the confidence intervals, which were between 4 and 16. So actually to measure a difference that would be expected, but more than chance, ours was 0.2 above, it actually would have had to be greater than 16 instead of 11.1. So the second thing is I had an ICU, they included patients that were under appropriate end-of-life care in that number, and so I had an ICU doc approach me and say, you know what, in the past I've always kind of talked to families when they came in the ICU about appropriate end-of-life care, but, you know, if you only measure me on my mortality, then why should I do that? Why shouldn't I save them all? So, you know, with our publicly reported data, we must be careful that we are not using misleading or you know, kind of more letting numbers lead to more conclusions than they really shouldn't. And also that we're not incenting the opposite behavior that we really want to. And then next, so what do we do when quality and safety information, how do I advise people to look at quality and safety information that's available on a hospital or a physician when you're choosing a healthcare physician and a system? First of all, process versus outcome. What I tell patients overall is look at everything and take everything with a grain of salt. So process measures are, while they're not specific, may not be specific to your particular illness. So, you know, you may not have heart failure, but process measures really give you an idea of the commitment and to the consistency and reliability that a healthcare organization has. So they are valuable even if they don't relate to your specific condition. Outcome measures, we were just talking about one of those, like ICU mortality. What I advise is to look at the big ones. Health Grades Clinical Excellence Study, Thomson Reuters rankings, the Leapfrog grades that recently came out. They certainly have been criticized and they have some issues, but they are kind of broad-based. Culture, again, I think the richest source of looking at culture in a particular healthcare system is their HCAHPS data. This is quote-unquote satisfaction or experience of care data, but it really gives you a kind of an overall feel for the kind of commitment and the culture of an organization. And finally, you know, there are people out there that think we're going to end up in the Amazon.com type healthcare system where you go on the internet and do all these, you know, kind of do the rankings. And I will tell you at this point in time, having recently had the experience of trying to help a 36-year-old cousin navigate how to get her breast cancer treated and dealing with oncology and radiation therapy and surgery and coordinating all that along with a second opinion, even for a physician, is very, very, very challenging, and there's a lot of gray areas. What I say is if you can find a physician that can act as your care navigator, or some other healthcare professional. That really is, people are not so much searching for wanting to rank in rankings as they are for a doctor they can trust or another caregiver. So, I think that's what I always advise patients to. I always filter all this information through the eyes of somebody actually involved in the system. All right, so I want to turn to another subject. Again, are we focusing on the right things and the things that matter most to patients in our healthcare system? Next slide. So smoke versus fire. This is a concept again, we've discussed a little bit with how to use numbers. And I'll turn again to mortality rates. One of the things that we look at a lot in our hospitals, and a lot of hospitals across the country look at, is our observed to expected mortality rate. This is a good number. It is not a pure number because, let's face it, some patients that come to our hospital are coming for appropriate end-of-life care, and the mortality is actually a good outcome rather than trying to push beyond the limits of our technology's ability to preserve meaningful life for them. So this is in the area of smoke. What I would call fire in this area, what we really strive for in our institutions is to look at what are the most common causes of potentially preventable mortality in our institution. Next, windmills and unicorns. Some of the PSIs and hacks that we're publicly reporting that we look at, we spend a lot of time on, but in many cases, we don't get a lot of bang for the buck, if you will, in terms of actually finding quality problems. Accidental lacerations is one of those that for the most part, occurs with very complex abdominal surgeries and is part of the procedure. And so there are adhesions from previous surgeries, and literally the surgeon cannot get to the place they need to get to correct the problem without separating those. So, iatrogenic pneumothorax, at one point that measure was including patients that had thoracic surgery. So actually, if you slice open a chest, air will get in. Retained foreign bodies is a big negative. It occurs in about 1 in 8,300 surgeries. Some people have tried to correct this, however, with x-raying every patient coming out of surgery with certain high risk factors. The problem with that is you prolong anesthesia time, you potentially are exposing patients to radiation risk, and right now the risk of doing that appears to be greater than the actual savings that you would get. So we have to be careful that the things we focus on are really the most important. Mortality we discussed. Coded data versus chart abstraction, as we move more to electronic records, we'll be more and more able to get direct data out of the electronic health record. Right now, for the most part in quality, we're relying on coding, which was really designed for payment, not for quality, and it does. So you have to, anytime you're using coded data, you really have to, if that's the source of a quality measure, you have to look at that with a serious grain of salt. And this last group, these are the icebergs. I think if you look at this, if you add hospital-acquired infections to sepsis, delirium, aspiration pneumonia, and deep venous thrombosis, the pulmonary embolism, which we heard a little bit about earlier, you probably account for 60 to 70% of avoidable inpatient mortality in U.S. hospitals. But if you look at the current measures and kind of the current programs we have for and kind of how we're measuring quality and safety in hospitals right now, the only one that we're even measuring to some degree is the deep venous thrombosis and hospital-acquired infection. So, I think to really get at ultimately, and there are a lot of hospitals doing this, including my own, that are delving into these areas, but we really need the system, if you will, and the oversight to be in areas where the highest return in terms of lives saved and mortality and morbidity saved, we really need to focus in that arena. Next slide, please. This is another area that, and again, this is something that we're struggling with as a healthcare system. This is really relating to surgery for the most part, but how do we appropriately apply technology? How do we get a balance between the appropriate use of technology, and then for cases that need it versus the risk? When we typically look at risk, and when you talk to your doctor about risk, a lot of times you're talking about the risk of the operation itself. or the procedure itself? What's the risk of dying, or what's the risk of having a major complication of that procedure? What the other part of that conversation is, what is the chance that procedure or that surgery is going to restore you to a level of function that's higher than where you are right now? And that's what we mean when we talk about moving from informed consent to informed choice. It's very important, I think, to preserve patient autonomy and to keep this decision within the physician-patient relationship. We found out in the managed care era that using purely criteria or panels or medical directors to try to make decisions that are not directly involved in the care of that patient, it leads to a lot of bad outcomes. So it really still needs to be within the confines of the physician-patient relationship, but I always say patients need to really go into these with their eyes wide open. I'll give you an example of how we're trying to do that here at St. David's with our coronary artery bypass, and we're piloting a program. There's something called the STS risk calculator, which for elective coronary artery bypass estimates the mortality risk for a patient having a heart bypass. So we're doing that with the patient consent and surgeon consent prior to surgery. And then if it's over a certain number, we are taking that to a group, again with the patient's permission, a group we pull together that consists of the surgeon, the cardiologist, the intensivist, and the anesthesiologist, and if available, the primary care doctor. So that group can get together and say, what's the real potential outcome here in terms of restoring full function versus the risk of operative mortality, and make a decision. The surgeon and the patient then can take that information and make a more informed choice than before. The patient can still decide that they want to go forward and along with the surgeon, but at least they're going with their eyes wide open and the right expectations. Next slide. End-of-life care. Next slide. Obviously, this is something we struggle a lot with as a society. One of the biggest reasons, I think, and from my career, is the loss of the doctor who you have had a long-term relationship and have developed trust with. Number one, loss of the number of physicians that fill that role now, but also them, when you're in the hospital or when you're in the situation, participating in the conversation. Now we have a lot of these legal and other categories that are quite frankly very difficultly interpreted both by patients and by caregivers. Living will, do not resuscitate, comfort care. So how do we get to appropriate end-of-life care? I would love to see the primary care doctors more involved. I think there's a chance of that as we move to a more kind of integrated electronic health record, and the ability to involve primary care, the potential for that will return. We've already talked a little bit about informed choice. One of the big problems we have with end-of-life care is, if we go into a coronary artery bypass and you're kind of, the surgeons, we're going to save your life, and all of a sudden that doesn't work, and they come to you and say, well, we can't do anything else. It's time to think about end-of-life care. Well, that's a big mental transition if you didn't expect to get there going into the surgery and you didn't go with your eyes wide open. Saving hope, this is a very important concept. I learned this very early in my career when a patient told me after a conversation with an oncologist that doctors didn't have the right to take away her hope. Hope belongs to patients. We are not omnipotent gods, as sometimes we've kind of gotten the feeling that we are at times. We cannot tell anyone when they're going to, we can give them advice, we can give them odds, but we don't know clearly when they're going to exit the world. So it's very important that we don't give false hope, that we really give information, but we act as guides. Maintaining control. This is one of the common mistakes I see very often, especially in young doctors talking to patients about end-of-life care. And that is they kind of take control away from the families. And, the first thing I would recommend always saying is, and I would never let a doctor take control away from me. what you say is, you're the captain of this ship, we're going to do what you want, I'm here to advise you. But families need to feel like they stay in control, especially if it's a doctor that they haven't had a long-term relationship with. If you meet a guy and the only credentialing you know of him is he's wearing a white coat and greens, and that's all you know about him, or his background, or his training and all that, the trust level is just not there to give full control over to them. And then finally, no regrets. This is a concept, again, with patients, in terms of you don't want to stay on too long. You don't want to try too hard for too long. At the same time, you don't want to give up too early. You want to have no regrets. One way to do that, especially when you have family making decisions for a loved one who is in extremis, I recall talking to a son about his father, and the way I expressed that was, I'm not asking you to make a decision and to tell me to take your father off the ventilator because that's what you think is the right thing to do. What I'm saying is, you know your father better than anyone else on earth. If he could, what I want you to do is to stand here, and if he could stand up and talk to us right now, what do you think he would say to us? So I think, our approach to this, control, not leaving regrets, not taking away hope, we can give a and going in with eyes wide open to any procedures, we can do a much better job with our end-of-life care. Next slide. Next slide. Oh, here we go. This is another slide I like. Again, you've heard today, we used to define healthcare quality and safety as access to the best trained doctors, nurses, and other caregivers, along with access to the latest technology and research. What it turns out, though, is most of quality and safety in healthcare is giving basic care with great consistency, great passion, and great reliability. I'm actually very optimistic. I have two sons that are crazy enough to have followed their father into medicine, and I think we are at a point where over the next several years we're going to see the technology assist us in moving patients and their personal health information across the continuum of care and reconnecting doctors with their patients to a much greater degree. That the technology, to some degree, has separated us at this point. So I'm actually very optimistic. But I'll end on that note, and again, we're going to do questions later, as I understand.
Well, and I'd like to really thank you, Tom, for a wonderful job. And I think that, Tom, you're one of our future leaders that understands the head, heart, hands, and voice. The knowledge of how we do things, what we measure, and your command of the data and the numbers is really the currency of the mind, or what we said in our recent movie, The Truth. Trust is the currency of the heart, which is hope, despair, the positive and negative emotions, and then teamwork is the third T of leadership, which is really putting the hands to work. But then the fourth T is training, and that is to give voice to not only the caregivers but also the patients. And so what I'd like to do, I'm about ready to go in to meet with Professor Christensen. What I'd like to do is to have Angela tell a little bit of her story, not long, Angela, so we could have lots of interaction, and then have Mary and have Karen and have Tom kind of interact on these issues. And I'll ask Frank to be monitoring the questions that will come in the lower right-hand corner of your screen. We are going to ask polling questions. We'd like to know if you want a deeper dive, which we believe almost every organization wants to know, more specifics on how we can equip our patients with the checklists and the actions they can take to be a fully vested team member and bring them into the hospital quality improvement programs. But also we'd like to ask whether more continuing education needs to be focused on our leadership teams. And so you'll see a polling questions in the lower right-hand corner. I will turn it over to Frank to facilitate, and then Frank will kind of rein in the discussion and the questions at the end to allow Mary to close us. So, Tom, excellent job. I think there's no question that as we look at the measures, the standards, and the practices as we move forward into the accountable care environment, we are going to need partners like Karen and Mary. And and Angela to help us. And so you have always been so open, Tom. I think you're a role model of the kind of quality and safety leaders we need. So I will now mute my phone and let Frank carry away. Angela, would you tell your story and your perspective as a very knowledgeable professional that's interacting with the system, and then we'll go ahead back and forth between our speakers, and Frank will monitor the questions. Thank you.
Sure. My name is Angela Clemente, and I had, before becoming ill, I had been in the medical field for 20 years. I worked both in pathology and clinical laboratory, and I also spent some time in the emergency room as a med-surg tech. After that, I went into the legal field for the past 14 years, and I had a surgery in 2009, and the surgery seemed to have gone well at first, but after the surgery, I became very ill. I couldn't eat and just was having a lot of difficulties. My blood work was coming back very poorly with protein levels, and I knew that they had taken a pathology report. They had taken a biopsy during that surgery, and I asked the doctor for a copy of the pathology report, which he did not give me. He said everything was fine and I didn't need it. Approximately a year later, I ended up very, very sick. My stomach was really swollen, distended, and I was hurting a lot. So I went back to the surgeon and said I was concerned that there was possibly a blockage, and could he, look at me. He said I would be fine. He pulled me into the hallway, said you'll be fine, and you could go ahead and make an appointment in 2 weeks. I left kind of discouraged and continued to hurt that night and ended up in the hospital, at which time I found out that I had cirrhosis of the liver. I had never drank or smoked or anything at all, no risky lifestyle behaviors to cause that cirrhosis. It's called cryptogenic cirrhosis. So, in other words, they're not sure exactly, where it came from or why, but I do have cirrhosis. And so, essentially, they told me at the time of the hospitalization that I needed to have a transplant. I thought they came in the wrong room. I just didn't have any risk factors or any problems. Prior to that, I was very, very healthy. So it was very strange to hear that. Since then, it's been navigating through a system that I can't even imagine other people going through that don't have the level of medical knowledge or legal knowledge to try to navigate through. More recently, we were trying to get my medical records from a hospital that was 5 miles away from, actually less than 5 miles away from another hospital that I was going to have an evaluation with for the transplant. And we spent more than a month. I wrote stat on that, meaning, we needed the information immediately. I couldn't get them. I couldn't get the records. I called Chuck Denham. I asked him to please help me try to get those records. Number one, it was very costly. They wanted $75 per disc. And number two, they, made me to fill out the forms, send them in. They wouldn't accept the faxed copy. I sent it in certified return receipt, and explained the date of that we needed the records for, and I gave them a good amount of time before we would have to have those records. But I did write stat on them saying that we needed them as soon as possible for that appointment. Lo and behold, we never got the records, and I had to cancel the transplant evaluation, which put my life at significant risk. and it took more than a month to finally get the records sent to Chuck Denham in Texas just to get them FedExed back here to me so that I could take them in for an appointment, which was only 5 miles away from my actual hospital. The records only needed to go from one hospital to another, which were only 5 miles apart. So that's pretty much what, the mess that I've gone through and trying to navigate through the system. And had I gotten the pathology report 1 year earlier from the doctor when I asked for it, I could have been treated, a year earlier, and I wouldn't be at the position that I am now, which is very, very ill.
Thank you, Angela. This is Frank Giotto joining, and I know that Chuck may not be joining the rest of this call, but he will be listening in. If you have any questions specifically to the topics that were discussed earlier, please take the time to fill them out in the lower right-hand corner. There is a box. But before we get to the questions, maybe I'd like to have Karen and Mary and Tom react to Angela, and in the context, what can we do to better equip ourselves, both as patients and as caregivers, to avoid these types of challenges with the fragmentation of care. Karen, would you like to start us off?
Well, one of the things that I'd really like to add to Angela's comments is she mentioned that she told us earlier that the records were sent to Chuck free of charge. So there was some sort of professional courtesy extended to him. For Angela to get those same records only, 5 miles away, they were going to charge her $75 per disc. That's just one inequity. I don't know what the answer is, but I think that's as dangerous as a life-threatening disease if you can't have access to your own records for a reasonable cost. So I guess maybe the tip is for those of us, we can't fight the system, but maybe we need to teach patients and families to make sure their doctors order a copy of the records for them, and that way they won't be charged. It's kind of a small thing, but it's a very big thing if you're battling all kinds of other challenges and have huge expenses associated with your healthcare condition. So.
Thank you.
Yeah, and I'll make a brief comment. Medical records is a incredibly difficult issue. Obviously, you think about the mounds and mounds of paper, and walking into a medical records area in a big hospital is something to behold. And it is a very, it's kind of a symptom of the lack of technology that we have in the infrastructure of healthcare right now. I think, 5 years from now, we probably will not be faced with the same situation. So much more will be electronic. I do agree with the idea of having a physician request. That's actually, I think that's legal rather than professional courtesy. I think any doctor, in most states, the law says that if a doctor requests information on a patient that he's involved with, you must give that information to him free of charge. And I think hospitals are allowed to charge patients for their records to defer the cost of obtaining those. $75 seems like a fairly aggressive, but I don't know the extent of the records. But anyway, it is a huge issue. There is, the health information exchanges, as they rise up, will really help this. There's even more kind of basic issues than this that emerge from this. Like you roll into the emergency room semi-conscious, it might be a real good idea that emergency room doctor have access to your medical problems and what medications you take and what doctors care for you in a fairly expeditious way before he gives you a drug that might interact with another one you're taking. So we are dealing with this, as a safety issue across the system. I know patients, just in being referred from the primary care doctor to a cardiologist, pretty much have to start over and do a whole nother history and physical when they see the cardiologist, because a lot of times he doesn't have access to the records or the labs or the imaging. So this is job number one for us to a large degree, at least here at St. David's, to try to move patients and their personal health information across the continuum of care safely and securely, and and efficiently. So I think it's something, but we are not there yet. And I agree with the advice of getting your doctor involved.
Well, and two, I think that Angela's experience, I hope you don't mind, Angela, if I'm speaking for you again, but one of the things that strikes me about it is that, and I've seen this in, front offices for pediatricians and outpatient surgery sites, that people who are working in support roles, at least it seems to me that oftentimes they forget that they're not working in, in a manufacturing company. They're working in a health care environment, and yes, there are lots of records, and it might feel like their jobs are very rote, transferring one record to another. But I think what seems to be missing in a lot of these offices is the culture of health and wellness and safety, and that it's really a job all about taking care of people, and it's not, to take someone's stat request has a meaning that's different than if you take a stat request in any other environment. So I guess that's what I would love to see personally, is that in this transformation of healthcare that we focus not just on nurses and doctors and other clinicians, but that we embrace every single person who supports patients in a hospital.
Well, this is Mary. I think it's a wonderful conversation, and it's regrettable that we are having it, but I'm glad we are. And there was a theme in Karen's, Tom's, and Angela's comments that, or presentations, which were all very powerful, and it really dealt with the difficulty in navigating the system, getting the right information at the right time. And Thomas, it was touching, and it's true. It's my own experience. It doesn't matter if you're a caregiver; it's still complex and confusing and difficult to be supportive of our loved ones or ourselves. So I think I have a new program for Chuck, Frank, and I think it's the GPS for healthcare. We need to know how to navigate, all of us, through the myriad of information and have the right information at the right time. And I think that may be, maybe that's our new mission, because the trouble with records is alarming. Regina Halliday, another good colleague, vigilant on this topic, and others who are just simply asking for the right to their own information. And Angela, your story is incredibly compelling and terribly sad and frustrating, and we wish you the best. So, Frank, I don't know if we have any questions that you'd want to share with us from our participants, and if they've been able to stay on or not. I know we started a little late, and we apologize for that.
Well, one of them would be, some of them, what can you do as an active patient, and what's the role of a patient medical record in that context of taking ownership of your records and seeing them through? So patient medical records and the role moving forward.
Well, I think that's a very good question, and I think one of the quick answers is to not rely on the official records, but also keep your own records. And I know in Karen's checklist and many other consumer-oriented products, they highly recommend that you keep your own medication list, that you may be the best source of information about your own care and your own health status, and always have that with you, particularly if you're meeting a new provider or going into the hospital. We never know when we're going to be rushed into an emergency room. Another rationale for good electronic records. But Karen or Angela, any thought on that in particular?
Yes, actually, with regard to the records in my case, I did all the right things. Had I asked for the pathology report and I didn't get it. Had I gotten it, I could have gotten treatment a year earlier. I had to literally drive to the hospital and get a copy of it from the hospital because the doctor didn't want to release it to me. He said everything was fine. And I knew by the way that I was feeling everything was not fine. And lo and behold, we find out it's certainly not fine. I'm now terminally ill. And the second thing was this all kind of goes into being denied records. I was denied the records once again because I didn't have $75. And just to kind of explain that, it does sound very high, and it is very high, but I was only asking for 3 MRI discs to go to another hospital. I had no problem having them send them to the hospital, but the hospital never received them. So I did absolutely everything correctly. I put in writing through their HIPAA form who I wanted it to go to, where I wanted it to go, and the date. I also put on there that it needed to be stat and exactly what I needed. Then they wanted me to drive 3 hours up there to the hospital because I'm 3 hours away from the hospital. The 2 hospitals are only 5 miles apart, but I'm 3 hours away. It cost me more than $100 in tolls and gas to get there, and then at least another $67 in parking because it's from New York City. So the issue was I was actually denied the records when I did everything appropriately that I needed to do because of the costs. Number one, I didn't have the money to get it. And again, these were only 3 MRI discs that we were asking for, not my full medical file. And even if they had wanted my full medical file, I've never been sick before, so my file is small. So I think the navigation in that for a patient that doesn't have medical or legal knowledge, it's life-threatening. It can be life-threatening. Such as in my case, but I knew how to kind of navigate that, and I had access to people that I could get this moving a little bit. But to have other people may not have access to Chuck Denham, and that's a very difficult thing to try to navigate through. And especially, I can't even imagine how it would be for an elderly person or someone that doesn't have the type of knowledge that I do medically and legally.
So I'll make a couple of comments.
Yes, please.
First of all, again, I would highly encourage, we talked about the value of having a primary care physician, even if he doesn't go to the hospital in this role. They're getting rare as hen's teeth in this day and age. We are not producing them very fast, and especially out of U.S. medical schools, because they are very challenged to actually make a living, believe it or not, given the average debt of about $250,000 that they come out of med school with. It's hard to face that with the reimbursement levels of that a primary care doctor has. But they are your best advocate here. And I will say we actually have created a system here at St. David's that we call Care Navigator, and this ironically called Care Navigator. This is a group of nurses that do exactly what you're describing, Angela, and that is they help facilitate the movement of information and from one doctor's office to another doctor's office to the hospital to the ER and also help to coordinate the care. A lot of times the other big issue that we find is that multiple doctors are involved in the care of a patient, and the ability to coordinate between those doctors to not have your labs drawn twice to make, it is really hard. So we've actually created that program here and finding tremendous kind of support for that. And then the final thing is I really encourage you to keep a list of your medications. I cannot tell you how important that is and how absolutely, despite tremendous efforts in trying to do this electronically and other ways, it is very difficult in this day and age for the healthcare system with multiple prescribers, with multiple medications, with multiple formularies to actually keep an accurate list of your medications, your medical problems, and the doctors that care for you, and some of their contact information. With those three things, it also would help, obviously, to know the dates of your MRIs and your imaging studies and other labs. But really, those three things are the most critical. The doctor's taking care of your medications and your medical problems. That is gold for a doctor that hasn't met you before when you bring that to him.
Thank you, Tom. And so would you say part of the building the relationship as part of the care team, engaging your primary care physician to help facilitate the obtention of those records, as we've gotten some feedback here through the Q&A that if it is through a doctor request, as Angela explained in our case, working through Chuck, she was able to get those records. So leveraging that team member as your navigator of care, to use your analogy, Mary, your GPS of care, really kind of working with them very closely to leverage that.
And remember, we have HIPAA and we have many kind of restrictions and policies and things that we make sure, that especially when we're releasing to you, we have to make sure you're you or that you're an approved receiver of that. Physicians that are collaborating and they're actively participating in the care of a patient are exempt from a lot of those things if they're actively participating in the care. So it really gives them the opportunity to kind of get through some of that bureaucratic red tape and to obtain records more rapidly.
Thank you. Karen, just to loop back with you, in the context of your the book and using that, maybe it's not a GPS, but is it part of the map process and how you've incorporated that in the book? And we've had a couple of questions as to where we can obtain the book and where we can obtain the checklists. So if you wouldn't mind kind of sharing that with the attendees.
Sure. The book helps to navigate in that it breaks a hospital stay up into 3 phases. That is preparation before going in. And so this is especially critical for any planned admission. People who come through the ED, of course, don't have that luxury to even go through that section. But many hospitalizations are, in fact, planned. And so we have the pre-stay planning. Then we have sections dealing with what to do while you're in the hospital, including lots of pages for taking notes with prompts for the kinds of questions to ask and the kinds of details to keep track of. And we have, actually little forms to help keep track of both medications and tests and test results and what test results mean. And then we have another section that's more about post-discharge, which we encourage people to start, really planning for discharge the minute their loved one enters the hospital. So we have sort of a transition section which talks about planning for that discharge, how to take good discharge notes, the kinds of details to go over at discharge. And then we have, at home, what are the common signs of trouble after a hospitalization, and the importance of monitoring those things every day, being very watchful, listening hard to what your loved one has to say, and then knowing who to contact if a trouble does arise. So we have sort of that flow of a hospital stay. And then currently the book can be purchased in bulk through us. You just go to www.partnerhealth.com, which is our website. There's a little video on the home page that talks more about the book and its features. We offer, bulk sales to hospitals and long-term care facilities and payers and employers. We just, pass on the discounts in our printing. We all know that the more, that goes to the printer, the cheaper it is. So, and then on an individual basis, the book is listed at Amazon.com. We have a free downloadable ebook at www.campaign0.org. But I caution you, we're updating the checklist and we're loading them this afternoon. So by 5 o'clock today, they have a fresher look, thanks to our great graphic designer, and they're updated. So, and if anybody wants to contact me with other questions after this is over, you can always reach me at Karen@campaign0.org or Karen@partnerhealth.com.
Great. Thank you. And just any other kind of comments, Mary, Tom, Angela, about this, and Karen, thank you, about this idea of patient medical records and some of the dimensions that, in working with organizations, can we go out there and really be more proactive in presenting ourselves into the healthcare environment?
Well, I liked Thomas's work on the windmills versus the iceberg, and we may have really identified an iceberg today, and where the real danger lies in this disconnect and lack of transparency and access to information that's critical. So, whether it's between providers, patients, or families, it's clearly an important link for us, Frank. And I think Chuck really helped open the conversation today and gave us permission to go here with it. More work to be done, clearly, and an opportunity for us to just be aware that we may have the most amazing practitioners and they can be life-saving, but only if the care is accessible. And this is probably one of those real important issues of access, including to access to information. So very, very interesting deliberations that I think really should follow from this in how to improve that part of our system.
I agree. I agree with Mary as well. And in my case, unfortunately, it was the liver transplant center that is not communicating with my primary care doctors or my primary care doctor. And, the doctor had repeatedly been asking for test results and information and made repeated calls and didn't get any calls back or return phone calls. So I now just try to get as many records as possible myself and then bring them into the physician myself, because they're just not communicating. So I think there's also an issue of communication breakdown sometimes between the bigger hospitals and the smaller primary care physicians' offices.
Just a hint, sometimes, and actually maybe Dr. Knight can, chime in on this, whether it's really effective or not, but we're all inundated with, voicemails and emails. What I've been recommending lately is that just go back to the good old-fashioned fax machine, or a letter, hand-stamped and marked urgent, that, somehow breaking through the clutter of communication, is really the first step to getting people's attention. Now, you sent a certified letter, Angela, right? And
correct.
And that still didn't get the kinds of attention you really needed. So, maybe this isn't right, but we've had some really good success with just faxing and putting in, 18-point font, a note about what you need to get some additional attention.
Yeah, and I would add that most hospitals have some form of a way, and again, I can't speak for that one. I know we in leadership really want to know about these situations. This is not good care, and this is kind of getting through all the levels to get the information to us sometimes can be difficult. But most hospitals do have patient advocates, or you can go direct. Say you want to talk to the CEO, the chief quality officer of the hospital, and explain this situation. You have an issue. So I don't stop with just if you're getting stonewalled, if this is within a system or within a hospital like that. But it is, I have to tell you, the sheer complexity. As a primary care doctor, when I was seeing patients at 50%, I averaged signing my name about 220 times a day on some form of a piece of paper. So it is daunting, so the electronics are really going to help us a lot, but we've got a little way to go. The other thing is that your insurer sometimes can help you if you're insured. They have resources to kind of get through some of this. They also have support resources, many of them that are horribly underutilized. Case management, a case manager person from your insurer should have been able to help you a lot, Angela, in this process. And a lot of them have this because it's in their best interest, obviously, as well. So, I think there's no perfect answer. But I will say this, that don't be shy if you're in a hospital. We view patients as a virgin set of eyes when they come into our institution. We are numbed every day by this environment, and if there's a safety risk, if it's something we see every day, it may not appear as that to us. So we really like having patients actively involved in helping us keep them and keep us safe as well. So, it's a complicated world out there. Our ability to change the natural history of chronic illness has fundamentally changed over my career. But our ability to do harm has also increased as well. It's a matter of wrapping around this incredible technology we have in diagnostics and therapeutics around an infrastructure to support it, and we're getting there. It's just going to take us a while, and we also need the culture to support that, and we want patients to be part of that.
Great. Thank you. Actually, you know what, Tom, this is a good segue to highlight a program that we've been putting together, including we have something called Speaker Link, which I'm going to touch on for the last couple of minutes here, and I'll expedite it. But I think it brings home very much kind of this notion of raising awareness and the key role of the patient. And Speaker Link was put together as a result, really a request from patient advocates who wanted to be proactive in educating organizations about their role and where they could really become a partner with the organizations to highlight some of these gaps, these performance gaps that we have, and also bring kind of the human side of it, not only at the front line, which is engaging obviously closely with the nurses, but really all the way up to the C-level, where sometimes these groups are a little insulated and spending more time looking at financials and sometimes missing that whole notion that this is really not a business about people, but this is about people's lives. So we put together Speaker Link, and Regina Holliday was one of the initiators. I think Mary was probably pushing her too, and it's a web-based platform that allows you, if you're part of an organization and interested in engaging patients to talk around a specific topic, we can provide you. You can go online, and it acts very much like a speakers bureau, where you can enter a specific topic of interest that you're seeking from a speaker. I believe we also have Karen, and we'll make sure to have Angela on there, and you can do some queries. You get search results that are both based on topic but also geography. So if you have someone that you're looking for to speak to in Austin, for example, Tom, you enter that location and it gives you a search results with a profile, the topics that they cover, and if there are any other areas of interest that they're willing to share with you. So we strongly encourage you to look at this website. It's free. We provide it for free. It's also a great way of identifying local resources, and if you do already have local resources that you're trying to share, they can just, speakers can register and access this site and in turn put in their profile. So again, this is speakerlink.org. And then a couple of highlights also. We have completed and released the second of our documentary called Surfing the Healthcare Tsunami. It was aired on the Discovery Channel over the last month or so. It's also available online, so you can actually go and see it, and I strongly recommend it. You'll see a lot of familiar faces, but we talk about these opportunities for improvement in healthcare, and many organizations use this documentary to set some of the context around some of their quality meetings or even their board meetings. So if you're involved in that capacity, I strongly recommend you watching it. And we're actually adding a toolbox to the documentary where certain key points that are addressed are expanded upon, and we're providing resources for organizations to leverage. Again, we're doing this, it's free of charge, and but certainly of great value. So with that, I'd like to kind of bring our discussion to closure and loop it back to really why we're here and why we're on this call, and it's about the patient, the family, and with that, I'd like to invite kind of Angela to bring us to some closing comments, and then Mary also, if you wouldn't mind, after Angela, just kind of wrapping us up.
I will, thank you.
Well, I think, I think what I've gone through is probably not, just me. I'm sure that a lot of people are going through this. I think if there's a way to try to teach family members also how to kind of navigate through this, once we can figure out the best way, to get through it as well, then that may be, very important. In some cases like mine, it's a life-threatening situation, so it's very dangerous to not have access to those records or to be denied records because of cost or because of, miscommunication or non-communication between the primary care doctor and the bigger facilities. So, all I would say is just continue to, try to do everything appropriate. I document everything that I'm doing at all times now and who I've spoken to. I think that's really important, so that if there's a time that you have to go back and say, okay, I spoke to this person and I didn't get these, I spoke to this person on this date and it's still been 3 weeks and I still haven't received them. Then you document each time that you speak to someone, and if necessary, go up the chain of supervision and try to get it handled that way. But in writing is always the best way to do that. And with me, I sent everything certified mail, return receipt, and I used the hospital's own request forms. So I didn't know what else that I could have done to correct that, but I say documentation. Document who you're speaking to and write it down, what times, what dates, and all of that, and then just keep at it.
Thank you, Angela.
Very good advice, Angela. Thank you. So, Frank, this is Mary. I'm just going to close on behalf of Chuck, and I know he's doing other good work, and I thank him for setting us up in this conversation. What comes to my mind, and I've been saying it a lot in the last year, we've been told, and physicians and nurses and all, that we need to be patient-centered, but we're told what to do and not necessarily how to do it. And I think this is another example of remembering the patient should be at the center. That is our primary concern and customer, and our systems have yet to reflect that, and there is work to be done, but conversations like this will guide us in the direction that we need to take. So thank you all for joining us today. TMIT is committed to improving care, and I think care could be improved by keeping these thoughts in mind in the next few days and weeks. Look forward to joining you on future calls. I want to thank Dr. Knight, Karen, and Angela very much, and Frank, thank you always for facilitating.
You're welcome.
Thank you.
Thank you all.
You bet.
So this concludes our webinar. The slides, transcripts, and CE request credits will be available on safetyleaders.org. Thank you very much for joining us today.